Okay, good morning, everyone. I'm Dr. Samardali, and today I'm going to talk to you about the condition of trigeminal neuralgia. So before talking about this disease, I would like to talk a little bit about the trigeminal nerve. And we know that the trigeminal nerve is the cranial nerve number 5. This nerve is called the trigeminal because it has three main branches. The first one is called ophthalmic branch, the second is the maxillary, and the third is the mandibular branch. It's very important to know that the ophthalmic branch and the maxillary branch are purely sensory, whereas the last one, the mandibular nerve, is both sensory and motor. It is motor because it supplies the muscle of mastication. So you have to know that the ophthalmic branch supplies the area in the green here, so the forehead and the top of the nose, whereas the maxillary branch supplies the area over the maxillary bone and the upper lip. And the mandibular branch, as I said, it supplies the muscle of mastication and also the skin over the mandibular bone. It's very important to know that the trigeminal nerve exits the brain through small opening. We call them foramina. And each branch of the trigeminal nerve exits the brain through one of those small foramina or opening. The first branch is called the ophthalmic branch, exits the brain through the superior orbital fissure. The maxillary branch exits the brain through the foramen rotundum, and the third branch, the mandibular, exits the brain through foramen ovale. And this is very important clinically here because those openings are very tiny and very small. So if there is any calcification around those openings, these calcifications can cause compression of the trigeminal nerve and causing trigeminal neuralgia. So now I will be talking about the trigeminal neuralgia. First of all, trigeminal neuralgia is defined as a long-term pain, and it is characterized as a neuropathic pain, meaning that there is a pain that results from compression to the nerve. In general, trigeminal neuralgia is broken down into either and atypical. And the difference between them that the typical trigeminal neuralgia is very severe, but occurs over a short period of time. Whereas the atypical neuralgia is less severe, but it's a chronic, meaning that it may last for more than 1 or 2 days. And 1 or 2 days of a trigeminal neuralgia is considered chronic because basically this disease most of the time occurs for a few seconds or a few minutes. Now, trigeminal neuralgia is considered to be a rare disease. And the reason why it's considered to be rare, because headache in general is very common, but headache caused by trigeminal neuralgia is very rare. It is estimated that 1 per 20,000 people suffer from trigeminal neuralgia. And this disease most of the time affects one branch of the trigeminal nerve. But the bad news is that this disease is progressive, meaning that with time it will affect other branches. So a patient may suffer at the end from trigeminal nerve affecting the whole 3 branches. It's very important to know that trigeminal neuralgia is triggered by many factors, and there are plenty of triggers. It can be triggered simply by touching to the face. So imagine that touching to the face can trigger severe pain. Sometimes trigeminal neuralgia is triggered by talking, by eating. Even sometimes air current can trigger trigeminal neuralgia. It's very important to know that those patients with the trigeminal neuralgia can't shave and sometimes can't brush their teeth because of the severity of the pain. Now, regarding the causes of trigeminal neuralgia, most of the time the underlying cause of trigeminal neuralgia is unknown. So most of the time trigeminal neuralgia is idiopathic. We don't know what is the exact cause. But sometimes the trigeminal neuralgia may result from compression of something that compresses the nerve root. One of those compressor is a blood vessel malformation. We know that there is a blood vessel, an artery called superior cerebellar artery. And this artery runs over the root of the trigeminal nerve. So sometimes if there is, let's say, if there is dilatation or aneurysm of this artery, it may compress the trigeminal nerve, causing a trigeminal neuralgia. Another cause is arteriovenous malformation. And arteriovenous malformation basically is a mass, meaning that the artery and the vein will form like a mass and can compress anything inside the brain. The third cause is multiple sclerosis, We know that multiple sclerosis is a disease of the upper motor neuron, but sometimes atypically present with a trigeminal neuralgia. And you have to suspect a trigeminal neuralgia for a patient who present to you with bilateral trigeminal neuralgia. You have to suspect multiple sclerosis in this scenario. Another cause is a tumor. So in general, any tumor inside the brain, like meningioma or arachnoid cyst, can compress the trigeminal root, causing a trigeminal neuralgia. So those are the main causes of a trigeminal neuralgia, but we have to remember that most of the time the cause is unknown. Okay. So here we can see that this is the root of a trigeminal nerve, if you can see it. And over the root of the trigeminal nerve, there is a vessel artery called the superior cerebellar artery. So imagine if there is aneurysm of this artery, or if there is maybe or arteriovenous malformation. Those disorders can compress the root of the trigeminal nerve and can present as the attached link here is a link for a case report for a patient who present with severe trigeminal neuralgia. And after doing multiple investigation, we found that this patient has abnormality in the superior cerebellar artery causing the. Here you can see that this is the superior cerebellar artery, and you can see that there is also arteriovenous malformation. And this patient was suffering from typical presentation of trigeminal neuralgia. After doing many investigation, we found that there is dilatation of the superior cerebellar artery, and we found this mass, the arteriovenous malformation. And the good news that there was complete recovery after doing embolization of this mass and after doing gamma knife radiosurgery. So this is very good to rule out secondary causes before try to treat the patient with carbamazepine and other medical treatment, because secondary causes are treated by removing the underlying cause. Okay, now regarding the sign and symptoms of a trigeminal neuralgia, nearly all patients with a trigeminal neuralgia present with severe facial headache, and it is severe. It's 10 out of 10. It is headache that is out of proportion, and most patients describe the headache burning or sharp pain. And sometimes the pain present in atypical location like the teeth, the lips, sometimes the eye or the jaw. So anything on the face can be affected. It's very important to know that this disease is a progressive with time, meaning that the attacks become more frequent and intense over time. Okay, so now let's talk about the diagnosis of a trigeminal neuralgia. And the diagnosis is based on taking good history, doing good physical examination, and doing the investigation. So history is very important here because you have to analyze the symptom. You have to ask about the headache, the duration of the attack, the triggering factor, the relieving factor, and to ask about other symptoms, because as I said, sometimes it is caused by other diseases. In physical examination, we start by inspecting the patient. Most of the time, it's negative, but if the patient presents with the pain, you will see the severity of the pain. Palpation, most of the time, it's not possible because of the severity of the pain. And as I said, palpation sometimes considered somehow contraindication to those patients because it can trigger the pain. It's very important to do full cranial nerve examination because you have to rule out other cranial nerve abnormality. As I said, sometimes the underlying cause is mass, and this mass can compress other cranial nerve. Also, limbs examination is very important because very rarely the underlying cause of trigeminal neuralgia may be stroke. So you have to rule everything. Now, regarding the investigation, the most important thing is to do MRI of the brain, and you have to do MRI with contrast, because some of the differential can be ruled out with the contrast, and some can be ruled out without the contrast. For example, if you suspect multiple sclerosis, you have to do the MRI with contrast. But if your goal is to see the nerve itself, you have to do it without contrast. And there is another type of MRI called 3D high resolution MRI. And this is very important for patients with a trigeminal neuralgia because we can see the nerve itself. We can see if there is atrophy of the nerve, something like that. Another thing is angiogram. As I said, sometimes it can be caused by arteriovenous malformation. So we can see this abnormality by doing angiogram. The last one, which is very rare to be ordered, is called serum alkaline phosphatase. And this enzyme is a marker for a bone problem. As I said, the foramina or the opening are very tiny. So a bone abnormality can result in trigeminal neuralgia. And I read a case about a patient over 70 present with a trigeminal neuralgia. And after doing many investigations, the underlying cause was Paget disease of the bone. So imagine that Paget disease can present with a trigeminal neuralgia. That's why we have to do serum alkaline phosphatase. Now, the treatment of a trigeminal neuralgia is broken down. Regarding the medical treatment, the most common drug we use is carbamazepine or Trigeminal. And this drug is considered to be the first choice of a trigeminal neuralgia. This drug acts by blocking the sodium channel, so it will decrease the threshold of the pain. But the bad news about carbamazepine is the side effect. It has many side effects. The most important are aplastic anemia and agranulocytosis. So you have to do CBC every now and then to check if there is anemia or if there is agranulocytosis. Another side effect is hyponatremia, maybe resulted from syndrome of inappropriate antidiuretic hormone secretion. And last week we had a patient who presented to us with hyponatremia after taking a large doses of carbamazepine. Another thing about carbamazepine that it's completely contraindicated during pregnancy because it may result in spina bifida and other abnormality. There are common side effects of carbamazepine like drowsiness, dizziness, headache, nausea, and vomiting. Okay, so besides carbamazepine, we have another drug like lamotrigine or topiramate, phenytoin, gabapentin, valproic acid. All of them can be used to treat trigeminal neuralgia, but most of the time we try to start with carbamazepine. Another method of a treatment is the use of intravenous infusion of a combination of magnesium and lidocaine. It's not widely effective. It's effective in some patients, but not all. Now, beside the medical treatment, we have other methods to treat trigeminal neuralgia. One of them is called gamma knife radiosurgery. And in this surgery, we use this machine to hit the root of the trigeminal nerve by radiation. And these radiations will, let's say, will cause damage to the pain fiber. And this method is effective in about 80% of the patient. But the bad news about gamma knife that it is not satisfactory after 2 years. So you may need to repeat it every 2 years in order to get a satisfactory result. Okay, the second method is the partial sensory root section. And this is very effective for patients with multiple sclerosis. In this situation, we induce an injury to the sensory fiber of the trigeminal nerve, but without causing any sensory loss. And this method is effective in about 70% of the cases. The last one is called glycerol rhizotomy. And in this method, the doctor has to introduce a long needle through the oral cavity to reach the foramen ovale. And after that, he will inject a small amount of a toxic material. One of them is the glycerol. And this glycerol material will kill the fiber, the pain fiber in the foramen ovale. And this is considered to be very effective. And the problem with the glycerol rhizotomy is that you have to repeat it every year in order to get a satisfactory result. Okay, so that's it about the trigeminal neuralgia. Another thing we have last Saturday, we have a case about a rare case, completely rare, and Dr. Bernard asked me to present it today. So the case is about a middle-aged female patient contacted Dr. Bernard last Saturday complaining of migraine. But she added that she had more than 50 episodes of facial palsy. So remember the name, 50 episodes of facial palsy. It was on the right side. And those facial palsy occur every night whenever she had air travel. And all episodes get resoluted of the symptoms shortly after descent. So whenever she had air trouble, she get facial palsy. But after landing, there is no facial palsy. So there is a facial palsy for 2 hours. After landing, there is no facial palsy. And she had 50 episodes of facial palsy. Could anyone suggest what is the reason for this disease?
I'm thinking some kind of air pressure, baro pressure induced compression of the facial nerve in the middle ear.
Yeah. Yeah, excellent. So yeah, that's true. That's the reason. So this condition is very rare, and the total number of reported cases is less than 10. So all the case reports are less than 10. And this disease is called facial baroparesis. And the exact cause here that we know that because of flying, there is obstruction of the ischemic tube. And this obstruction will know that the course of the facial nerve is very close to the middle ear, and this high pressure will cause partial ischemia of the nerve. But after landing, there's complete resolution. And this is very rare. Less than 10 cases are reported till now. Another thing you have to know that most of the cases are caused by scuba diving, not by flying. Okay, so the symptoms should be resolved upon equalization of middle ear and ambient pressure. So there is no treatment needed for this case because it is completely reversible. Sometimes if the disease progresses after landing, we have to do surgery in order to equalize the pressure by doing maybe tympanostomy or mastoidectomy or tympanoplasty, any of those surgery in order to equalize the blood pressure. And that's it. Thank you.